Hello, everyone, and welcome to today's webinar in the Public Health Webinar Series on Blood Disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. I'm Vanessa Byams, and I'm a health scientist in the Epidemiology and Surveillance Branch in the Division of Blood Disorders at CDC. I am pleased to be with you and will be serving as today's moderator. Today's topic is It's All About Choice, Findings from a Survey on People Seeking Care Outside of Hemophilia Treatment Centers. Before I introduce our guest presenter, I'd like to go over a few points and helpful tips for joining this webinar. Upon joining the webinar, you will see two audio options. You can opt to listen via the speakers on your laptop or by using your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with the phone and access number and audio pin. All audio will be muted. At the end of the presentation, there will be time for questions. To submit a written question, please use the questions area of your toolbar. The presenter will respond to as many questions as time allows. Today's webinar will last approximately 1 hour. Please note that this webinar will be recorded. First, we will begin today's webinar with an audience poll. We are interested in knowing more about all of you joining us today. And the first poll question will come up shortly. Where do you reside, inside the US or outside the US? Please take a moment to enter your selection. Okay, we are predominantly inside the US. Thank you. 87% inside the US. The next poll question is coming up shortly. Tell us about yourself and what your role is. And we'll give you a moment to enter those selections. All right, 30% of folks provide care to people with bleeding disorders. And thank you for the rest of you, all of the variety of groups we have represented here. And there is another poll question. Among those of you who provide bleeding disorder care in the US, please tell us if you're on staff at an HTC or you provide care outside the HTC network. All right, 89% of attendees are on staff at an HTC among those who do provide care. So thank you so much to everyone for responding. All right, well now it is my great pleasure to introduce today's presenter, Wendy Owens from the Hemophilia Federation of America. Ms. Owens is the Director of Research at HFA and the Principal Investigator for CHOICE, a collaborative project between HFA and CDC. Prior to joining HFA, Wendy was the founder and executive coordinator for the New England Coalition for Affordable Prescription Drugs and the advocacy coordinator for the New England Hemophilia Association. Wendy began her career in the private sector, starting and running several companies in educational technologies and materials engineering. For over 13 years, Ms. Owens was an advisor to the U.S. Secretary of Commerce and the U.S. Trade Representative on Information and Communications Technologies, Services, and Electronic Commerce as a member of an Industry Trade Advisory Committee. Wendy, welcome, and let's begin.
Thank you, Vanessa. I would like to extend a thank you to my colleagues at HFA and also at the CDC for all of their support and help during the Choice Project while it was running, and also afterwards as we're doing the data analysis and making the information available to our community at large. So a little background here on the purpose and where we went with Choice and why we were decided to do Choice, and I suppose why the CDC decided to offer it as a surveillance study. We know that approximately 33,000 people are treated at HTCs, but not everyone attends an HTC and receives treatment there who has a bleeding disorder. So the estimation was about a third of people with bleeding disorders in the US do not receive care at a hemophilia treatment center. And the question is, how are they doing? Who are they? What are their disorders? Are they severe? Are they mild? And this was something that we were looking to find out. So overall, the purpose of Choice, which is community having opportunity to influence care equity, as we were looking to give people who do not receive care at HTCs a voice in their care, was to collect this information, and maybe we can estimate their disease burden, figure out how do we plan for them, they would allow us to help make decisions about overall broad planning, including the CDC and their ideas about who these people are and how they service them, as well as HFA, how we service this community. And then also to contribute data on the public health, into the public health surveillance program for the prevention of complications of bleeding and clotting disorders. So as I mentioned, this was under a collaborative agreement with the CDC, with HFA, and the focus was on non-HTC patients. So specifically those people not receiving care at federally funded hemophilia treatment centers. The project ran from October 2011 to September 2015. And our outreach and recruitment allowed us to identify pockets of non-HTC patients around the country. And we are figuring out whether or not they may be underrepresented, and there may be other efforts that we can do to help them. And it ended up, and I will go into this further in a little bit, that anyone could take the survey, anyone with a doctor-diagnosed bleeding disorder, but also people who felt that they were symptomatic carriers as well. So we did open this up to quite a few people. And the reason being is that in discussing the project with patients and talking about federally funded HTCs, the majority of people that we had talked to had no idea whether they received care at a federally funded hemophilia treatment center or if it was just the hospital down the street on this corner right next to the McDonald's and Wendy's, and that's where they receive their care. So the value of this data, what's going on here? So we're looking to see if these patients were susceptible because of their underlying disorders and they weren't receiving the care that they needed. Did they have certain complications and how severe those were? And we wanted to increase education and outreach for these patients and their specific providers. So through the course of finding these patients, we also found providers across the country who serve these patients in some capacity or another. What was very critical in the process of engaging patients who do not receive care at federally funded hemophilia treatment centers was to make sure that they felt like their data would be secure. We had a very open dialogue with our community and other stakeholders about how to secure this data. We work with a security firm specifically to make sure that we have the right protocols in place during the data collection and that we could reassure people who were going to take the survey that their data would be safe. Another part of the transparency was that people could review the questions on the survey in advance of taking the survey. So the survey questions were provided online in a PDF format they could access via a computer or their phone or their tablet. And they could say, okay, what questions are going to be asked and am I comfortable responding to these questions? They were not required to respond to all the questions, so they could pick and choose. So what was critical here, and we were sort of forging new territory to some degree, was to ask patients directly for this information. So it became a true community effort. In order to ask patients and get back from them the responses that we need in order to support and help them, we enlisted over 150 community members to contribute to the development of the survey itself. So we used the participatory action research method. We went out, we said, hey, these are the questions we're going to ask you. Are we asking these questions correctly? Is this how you talk about your disease? Are these the right responses? And we had a tremendous amount of participation and feedback, and we learned a lot from patients as to how they talk about things like inhibitors, how they talk about their treatment plans. For example, they don't normally use prophylaxis or on-demand. That's not part of their vocabulary. They use it in a variety of ways. So in terms of content, there were 3 assessment tools, and we collectively refer to these as the survey. They were for adult men, adult women, and parents or guardians of children with bleeding disorders. And the surveys requested this information. And this is for all 3 groups. This information was requested. We were able to collect some significant amount of patient satisfaction data using the RAND short question, 18-question satisfaction survey, which came out very interesting, and we'll talk a little bit more about that. We did have a longer survey for females because we were asking about onset of menses, heavy periods, reproductive history, quality of life, and quality of care, and what's it like to be a female with a bleeding disorder. For children, it was substantially same as the male and females. If it was a female child, they talked about the onset of menses and some other gynecological questions, but excluded menopause. And male and female versions of the child survey asked whether or not the parent had discussed a transition from pediatric to adult care with their child. And that's a very important issue right now. The female surveys were great, and we collected a lot. And then the last question on our survey was, is there anything else you'd like us to know? And as you could imagine, we got an earful, let's just say, from people about whether they were happy with their care, unhappy with their care, whether they were angry, what's been happening with them. So there was a lot of information that we garnered from that last question, which we will be putting out there shortly in greater detail. Now, as I said, this was a very important community effort for HFA. We worked with 10 of our member organizations, sometimes referred to as chapters by NHF. We referred to them as member organizations. We contracted with these 10 specifically and provided some funding to cover their administrative costs, and got a tremendous amount of help from these groups. Some of the leaders held special meetings at their locations that were more convenient for people to come to, and they had iPads and our paper surveys there for people to take. And we actually had one group actually take a stack of paper surveys out to a location where they knew there were a lot of folks with bleeding disorders who were not receiving care at the HTC in their location, and gave them the paper surveys in Spanish and had them take that. So they went all out, these groups. Now, that's not to say that we didn't have our other almost 40 other additional member organizations support us, plus NHF chapters. We really worked hard to get the word out. These folks used a lot of word of mouth and encouraged those people who had family members that they knew were outside of the HTC system to please take the survey. In addition, HFA leveraged its own programming. So these are a few examples. We went through our Blood Brothers program, our Helping Hands program, our Blood Sisters program, advocacy. We used Facebook, we used Twitter, we used Instagram, we used email blasts, and again, a lot of word of mouth. So social media was integral to our recruitment process. We were able to collect data on which postings people responded to best. So we know that, what time of day, what level of encouragement, what information was provided. So we've managed to come up with a system that we found worked as we recruited over the years. In addition, as part of our data collection, we had a couple of home care companies distribute our Choice Project brochures which you see on the left, in English and in Spanish. And these reached a mailing list of approximately 10,000 bleeding disorder patients. So this would be non-HTC and HTC patients, but we were able to reach quite a few people. They actually inserted the brochure into the mailing, the monthly mailing for these patients that they had as their patients, and it was received that way. In addition, we emailed and mailed a CDC-produced provider fact sheet, which is on the right, to hematologists around the country, including over 1,700 that we identified as non-HTC hematologists. So those went out, and we did receive responses from those hematologists asking for brochures and directing people to take the survey. So we were working hard to find these people that are non-HTC patients, some hiding in plain sight, others we were really working hard to delve into those, again, pockets around the country where they were. So the survey dissemination went through April 2013 to July 2015. It took about 20 minutes for people to take the survey. The female survey being about 16 questions longer, took a little longer. The survey was available in English or Spanish. It was online or on paper. Most of people took the survey online. In fact, 97% of our surveys were completed online. The survey format was such that you could take it on your phone, and you could take it on your tablet, or obviously on your laptop or desktop, but that made it highly accessible to a wide variety of folks. So that was, and their choice was online. They could request a paper survey version be mailed to them if they couldn't access the online version. So we made this very clear. Part of our dissemination efforts and part of our promotional efforts included writing up articles that our member organizations could include in their newsletters, and providing them with other ads, for example, that could be included in newsletters or on their websites or on their social media pages. There were two versions of the survey. So we had the three versions, being the adult male, adult female, and the parent or guardian version. And then we had a pilot version that we did, which ran from April 2013 to January 2014. And then the results were reviewed. We took a look at the results. We received more input from the community about the surveys and the feedback from them about, are we asking these questions well? Are these responses what you expect to see in the survey? And we updated the survey to minimize the write-in responses where options had been available. So we were learning along the way as we saw what people were writing in. If they were writing in something that they could have otherwise responded to by just checking a box, then we revised our language so that it was obvious that that was one of the options versus writing something in. Then we launched the final version of the survey in March 2014, and that ran through the end of July of 2015. Now, once we had the surveys, we had to make the determination of whether or not the person who had taken the survey would fall under our definition of a non-HTC patient. So you see here our algorithm for making this, this determination. We did learn that we needed to put in, as we were building the survey, this series of questions that helped us establish objectively whether a respondent received care at an HTC or whether they did not, or whether it had been a while, for example, at least 4 years since they had received care at an HTC. So out of all our respondents, 22% were non-HTC patients. And we applied this algorithm, and we're very careful about our identification of these folks. So we had our patient distribution here that you see from around the country. 6 states accounted for 55% of our participants: Texas, Florida, New York, Massachusetts, Illinois, etc. We did get some from Puerto Rico. You see our Texas and our California larger populations. We did have 3 member organizations that contracted with us doing heavy promotion in Texas, also New Mexico. But California, they just stepped up right away, even though, of course, they're a bigger state, and you would think so. Florida as well, there are lots of folks there. So here's our data breakdown. So 805 eligible completed the survey. We did have people come in and take the survey who were from outside the U.S. Quite a few people took it in Spanish from outside the U.S. and we filtered those out. Again, 97 completed electronically, 3% completed on paper. So I'm going to just go through some of the data. This data, I will say, is available by the posters that we have presented. And if at the end of the webinar you are interested in receiving copies of the posters we have done for either the non-HTC data for choice or all of, we actually have done also the aggregate data posters as well, please let us know and we can share those with you. So one of the, going into this, some people had asked me, well, do you expect to see mostly mild and moderate patients who do not receive care at a hemophilia treatment center? And as you can see, we have a good number of severe A's. Our B's, not as much. We have more milds that came in, a good number of von Willebrand's. We did get platelet disorders, and our other bleeding disorders would be those rare disorders, the factor 1, the factor 5s, factor 7s, those are included. Our age breakdown here, mostly our 20 to 44 folks that responded. We did have 9 over 65, which is good to see that we have a growing population in that age group. It was interesting to see about a 50-50 split between female and male respondents for non-HTC. And we had quite a few people reporting multiple diagnoses. So this was the question of, what is your diagnosis? And we had people reporting combination diagnoses, for example, hemophilia A and von Willebrand's, a platelet disorder in von Willebrand's, and then a combination of other bleeding disorders. And you can see the age of diagnosis, more than 24 hours, is quite heavy in this population. And then our mean and median for diagnoses is as you can see, they're almost 14 and about 6.5. So again, I'm just going to sort of chug through some of the data just so you can see, you can imagine in your minds what you've seen, and now this is what we've gotten. So here's our treatment. So we do have about 58% using the recombinant factor concentrate for hemophilia A or B treatment. For von Willebrand's, much more non-plasma or topical agents, and some people using the plasma-derived clotting factor. Interesting in our race and ethnicity, this population responding to the surveys represents a more ethnically diverse population, particularly in the Hispanic area. We had, in the US, it's about 17% Hispanic. We had a 27% representation, but we're disproportionately lower in terms of African American. So African American in the US represented about 13%, and we were less than around 4% here. Employment status, about a little over, about 50% employed full-time. This is the commercial insurance breakdown, our insurance overall, with Medicare and Medicaid are both combinations. Some people had Medicare, Medicaid with a combination of something else, and we had 6% that were uninsured. But most of the respondents were commercially insured. Our education levels, what we found. Income levels, a little skewed a little bit to our 44% in our lower income levels. And then treatment regimes, 62% infuse at home. And in terms of self-infusing, 46%, and 32% have a family member infuse them. So 76 had used clotting factor in the last 12 months. And you can see we've changed language a little bit here so that we have two categories in terms of using clotting factor to prevent bleeds or practicing continuous prophylaxis. And so we worked this a little bit to make sure that we had some language that corresponded to what other studies have found. Females using in the infusible treatment product were less likely to practice home infusion, is one thing we did find. So usual place of care. We were wondering, where do these people receive their care? And multiple responses were allowed in this question. 14 non-HTC respondents indicated that they usually receive care at HTC, but 7 of these were determined to be erroneous. And the other 7 were determined to receive care at HTC, but not in the past 4 years. And so it's interesting to see where they receive care. And also about 89% visit a hematologist. And then the next would be a family. So when they go to their doctor's office, they talk about a family practititioner. But otherwise, 89% of this population does receive care from a hematologist. 29% of non-HTC patients delayed or did without care in the last 12 months for the following reasons. So care being too expensive. What we did find that children were less likely than adults to delay care or do without care in a 12-month period. Females were less likely than males to see a healthcare provider regularly for their bleeding disorder, and they also see them less frequently. Females do. And that males will seek treatment for their bleeding disorder in advance of a surgery or some other kind of activity that may cause them to bleed, but women generally don't. Only 8.5% of women do. So we've been using the data to learn a lot, and we actually were looking at the data along the way, figuring out not only were we asking the right questions and using the right and offering the right responses, but we were looking at it to improve HFA's advocacy and programming for women and for everyone. And we were hoping that what we would be able to do is collect data that would allow us to let our community stakeholders, whoever they may be, understand the characteristics of non-HTC patients. Really try to dispel misconceptions like all non-HTC patients are mild. None of them have an inhibitor. They all live in rural areas. But that's not the case. You know, we have seen a good distribution across the country. We have severes, milds, and moderates. We do have patients with inhibitors do not receive care at HTCs. And we learned about reasons why people choose not to receive care at a hemophilia treatment center that's federally funded. There's a lot of them. So some of it is lack of trust in the HTC system. They may be focused on other comorbidities, and they feel that they can work with their doctor to manage their hemophilia, even if it's severe. And you know, they've been treating themselves, they've been treated for a long time. These are usually older gentlemen, but they have other comorbidities in which they need to focus, and they're focused on treating those. And there is also preference of provider. Some people prefer to stay with the provider that they have, or may not like, for example, the providers at the HTC. So there's a number of reasons, and yes, the location does play into it, cost plays into it, and other reasons. But we're trying to figure out, you know, all the reasons. What are those reasons, so that there's not just any misconception about this population. So how are we getting the results out there? As of late, we have done a number of posters at these various meetings. This includes both just strictly non-HTC data, but also the aggregate data that we collected on HTC and non-HTC patients together. And we will be producing manuscripts. I will be working with the CDC to produce manuscripts on our non-HTC data, methods and demographics, their treatment, health and utilization, inhibitors and infectious diseases, women's experience, joint disease, etc. So those are forthcoming. What was important to HFA in this process is disseminate this information to the community that participated in the development of the survey and was so forthcoming with their help and their responses to the survey and the honesty in which they responded. We make sure that we get this information out to them. So we are doing this through our annual meetings. Well, we do have numerous programming sessions. We do over 200 a year around the country. We are giving this information out at our member organization meetings. We have what we call our Teach Immersion Days, where we bring folks in for a specific topic and are able to support the topics that we cover with this choice data. And we're able to use this data to support efforts at our legislative days, both in the state and also when we fly people into Washington, D.C. to go on the Hill there. We will continue to disseminate this data in many different ways. And hopefully this will be useful data to the people who need it most. As to what's next, we are doing a Choice 2.0. We have updated and added questions. We have an IRB. We are doing the survey through our HFA Community Research Portal, which is on a peer platform, essentially a registry platform, that allows the participant, the patient as that may be, to control their data and who has access to it, who sees it. But to do this once again and collect this information in a longitudinal study so that we can look at it at specific breakpoints, whether that be 6 months, a year, 18 months, etc. And we're very excited about that. That should launch hopefully by the beginning of October. We'll have this all online and ready to go and be collecting this data once again. And we have added to it some interesting questions. So hopefully things that we have not been able to discover for the first time will be just, in this iteration, we'll be learning more. So that's my presentation of information, and I look forward to responding questions that you might have. And I will let Vanessa take over again.
Great. Thank you so much, Wendy. And I want to thank you for your efforts and your leadership on this project. We're now going to shift to the question and answer section of the webinar. Again, in order to submit a written question for Wendy, please use the questions area of your toolbar. So first, to kick things off, Wendy, I wanted to ask, and for those who are listening, how does the non-HTC group compare to the HTC group in this data set? People might be wondering.
That's a very good question, but a question that I can't answer. And the reason being is that when this project was initiated, we were looking to collect data only on non-HTC patients. The fact that we did collect data on HTC patients was an accident of the fact that most people do not know whether or not they receive care at a federally funded hemophilia treatment center. Consequently, we were not asking questions or looking to garner respondents from both groups, I should say, so that we could make some kind of comparison. So we will not be comparing the data in choice, non-HTC versus HTC.
Thank you. All right. And please submit your questions if you have any. We've got one other question right now. So you stated that you worked with 10 contracted member organizations to recruit participants. How was the project promoted in other states or with other member organizations who might not have been directly funded?
So because we have our HFA member orgs and they're very supportive of our efforts as we are supportive of theirs, we work with them to provide them specific materials. As I mentioned, articles that were pre-written, ads, asked them to please repost our social media post about choice, and we provide them with information on the project itself. And I think what was very important in this process was not only transparency with the potential participants, but transparency with our member organizations as to our goals of the project, our target for the project, how the data was going to be used and collected, and the security of the data. So they were very forthcoming in their support as we promoted the choice to the entire community.
Great. Our next question is, have the results of this survey been published? Where can we view this data?
So we have published some of the results of the survey, and you can request copies of the posters that we have done. We have done posters that are strictly on the non-HTC patient data, and we have done posters on the aggregate data as well. And so when including one poster that focused strictly on the von Willebrand's patients, which turned out very interesting to see what the group looked like. So if you'd like copies of those posters, or if you just want copies of the non-HTC data posters, you'll be able to email us at the end of the webinar, and those can be sent along to you.
Awesome. Then the next question is, are you surprised to see that percentage of severe patients treated at non-HTCs are quite high? Are these patients mostly located in the remote area? That's a good question. That's
a very good question. And I would say we went into choice with no preconceptions about what we were going to find. As I said, I think there were people who had preconceptions about what we might find about this population. So I would say, no, not surprised, because that was our intention, was not to be surprised, but just to take it at face value. And no, these patients aren't just in rural locations. There's a number of reasons why non-HTC patients aren't receiving care at HTCs. Some of it's cost related. Some of it's their insurance is not taken at HTCs in their area. There could be in urban areas basically a space where you just don't have an HTC close to you, or it may not be as accessible. And then there are a number of people who also choose not to receive care, again, at an HTC because they're wanted to focus on a comorbidity. They prefer the doctor that they're seeing. They may be distrustful of the system itself. And so not surprised, but interesting to find that.
Mm-hmm. And I would agree from the CDC perspective as well, in terms of we didn't have, I don't think, any sort of preconceived ideas about, what the severity might be in this population. And I think the main point from our end was we just kind of had no idea. And so that was really the impetus for this, is to just find out, how to describe these people and sort of what were their diagnoses. So, but as you say, it has been interesting to see what has come back thus far.
And I think I would add to that when I talk about finding pockets of non-HTC patients, you also may find in those pockets an excellent private practitioner who is serving patients well, or a treatment center, so to speak, that is providing comprehensive care, but they are not part of the federally funded HTCs, that whole system.
Definitely. So we have another question. How representative is the non-HTC sample, given the difference between the earlier estimates of about a third of persons with bleeding disorders do not receive care in HTCs?
Well, I think you have to look at the time period. When the 1/3 number came up, that was in 1990. So that was some time ago. And consequently, I know there have been additional federally funded hemophilia treatment centers brought online, and people are having better access to that care, consequently, as just a location as itself. But I think that, it's not perfect that I couldn't say that, yep, it's 22% of people do not receive care at a federally funded hemophilia treatment center, because I do think that changes. I think there's some variation based on if people are moving, if they change insurance, and what difference that might be. So somewhere between 22 to 28 or so %, I think is what folks are estimating right now.
Yeah, and I would just add that, with this type of project where we were directly surveying people, it is a little hard to make the leap to it being representative. The typical sort of gold standard design for representativeness would be more of a population-based surveillance, and that the original data that came out in the 90s was a population-based surveillance system, but those are also quite cost prohibitive and have some other challenges. So this definitely was a good, attempt to see, again, looking into the unknown of, who are these patients and where are they and what are their issues. So I think for the representativeness question, we'd probably have to look into some other design aspects. All right, let's see, we have another question. For the female respondents, was it clear if they were answering for a child or for themselves as the patient?
Yes. So there were two versions of the survey for females. There was the adult female survey, and then there was the child survey, which if the child was under 18 years old, their parent or guardian took the survey on their behalf. And the language within each version of the survey was very clear, and when you were online, you were automatically given the survey that you chose. So if you said that you were taking the survey for yourself, then that was a survey you received. If you were asked initially, are you taking this survey for yourself or your child, and you choose your child, you were automatically entered into that survey.
Yeah, thanks for the clarification. And I know probably with the different versions, it might be a little confusing. The next question is, did you ask about number of hospitalizations in the last year or 3 years?
Yes, we did. So we did ask about the number of hospitalizations and ER visits in the last 12 months. So that was something that we asked. And I don't have that data right here, and I can't get to it because I'm the one sharing my screen, but that information is available on the posters.
And again, and reach out to us if you would like to receive those posters. The next question is, can you go back to the slide on why respondents didn't go to an HTC? To what extent did insurance barriers play a role?
So what we focused on was foregoing care or delaying care. And so insurance carriers played a role to about 12% of these folks. So it's not, the question was not, why don't you receive care at HTC? This question focused on delaying and foregoing care. So we never asked them it directly, well, you don't receive care at HTC, why don't you? And the reason we couldn't is because we first had to make the determination of whether they receive care at a federally funded HTC or not. So we did get responses in the final question where we asked, is there anything else you'd like to tell us, where people provided their reasoning for choosing not to receive care at a federally funded hemophilia treatment center. But that was not something that we asked directly.
Mm-hmm. The next question is, are we able to see if these patients, people seeking care outside of HTC, have an inhibitor or had developed an inhibitor before?
Yes, so we did ask a series of inhibitor questions, and our question was, have you ever been told by a healthcare provider that you have an inhibitor, you had an inhibitor, and then has it been resolved? So we do have inhibitor information in this version of the survey. In the next version of the survey, we ask even deeper questions about inhibitors, such as which product were you on when you developed the inhibitor, what was your dosage on that product, and so forth. So, but just for the choice 1.0 for comparison purposes, we do have information about inhibitor patients.
The next question is related to recruitment. Which recruitment methods seem to work best?
That's a great question.
Yeah.
So we found, and when we asked how people found out about the survey, we found that it was through the HFA website, materials available on there, then through social media, and then via word of mouth. So those were our basically 3 levels. It was critical for the word of mouth, and I will say this, for the older gentleman who were a bit reticent about even considering to take the survey. It was very important for us to get their buy-in, and particularly the thought leaders in that group of folks. And then that was very much via word of mouth, because some of them have basically exited the HTC system for their own personal reasons.
Mm-hmm. And it is interesting to see sort of the impact of the social media and how, you know, how that's a vehicle and how people are using that more and more, and how, you know, we were able to pick that up, that that's where people were sort of entering the project. So. All right. Any last questions out there? And as you can see, here is an email. So again, if you would like copies of any of the posters that have been presented, please use this email to reach out. All right, well, I would like to thank Wendy again for an excellent webinar presentation. Just to let everybody know, this webinar will be archived and the content will soon be available at CDC's Division of Blood Disorders website, as shown on this slide. And on behalf of the Division of Blood Disorders at CDC and the Hemophilia Federation of America, we are delighted that you could join us today in this important topic. Very shortly, you'll receive an email asking for your feedback on today's webinar, so please respond with your comments, as we want to ensure that this webinar is a helpful resource to all of you. If you have any additional questions about today's presentation, please contact Cynthia Sayers at csayers@cdc.gov. And please join us next month on October 12th, when we partner with the International Society on Thrombosis and Hemostasis for our joint webinar recognizing World Thrombosis Day. Our guest speaker will be Dr. C. Michael Gilbert from Harvard University. Dr. Gilbert will be speaking on advances in reducing the disease burden of thrombosis. We thank you so much for joining us today, and have a great afternoon. Thanks, everyone.